Good evening, students. Welcome to you from Sri Rama Hospital, Jagaipet. Today, let us study about the neoplasms of the kidney and the ureter, and later the infections. The tumors of the kidney. Benign and malignant are the classification in the benign tumors: adenoma, hemangioma, angiomyolipoma. It is a rare tumor. Sometimes it may metastasize. Though it is a benign tumor, it may metastasize. That means it may show malignancy features. Then malignant, the malignant lesions can be from the kidney parenchyma. That is, in adults, it is carcinoma of the kidney, also called as Gravy tumor. In children, it is called Wilms tumor or nephroblastoma. Then malignant tumors of the renal pelvis. This is called the transition cell carcinoma of the pelvis and ureter, also called as the upper tract transition cell carcinoma. Rarely it can be due to squamous cell carcinoma. How squamous carcinoma can occur in pelvis of the kidney? Pelvis is lined by transitional cells. Then how do you expect squamous cell carcinoma to occur? Very good. It is due to metaplasia of the epithelium. Benign renal swellings are not clinically palpable. Can you tell me another example where benign swellings are not clinically palpable? Other organ where benign swellings are not palpable. Very good. Liver. The adenoma of the liver and hemangioma of the liver are not clinically palpable. And of course, testicular neoplasms also, they are also not clinically palpable, benign swellings. They are diagnosed only with arteriography or ultrasound scanning. So all palpable solid masses from the liver, or kidney should be suspected as carcinoma. Wilms tumor. It is the commonest solid tumor of the childhood and seen frequently during third year of age. It develops from embryonic nephrogenic tissue, that is the mesonephric dome, or mesonephric mesodome. This is a specialized tissue which converts into, or which differentiates into kidney. Kidney is developed from metanephric cap. So that is a differentiation of mesonephric mesodome. So we have already seen that it gets completely differentiated into kidney. Sometimes the mesonephric mesodome cells, they may remain in the kidney without getting differentiated. So these embryonal cells can develop into a neoplasm. That is called the Wilms tumor. Hence, histologically, mesenchymal elements like there is a blastoma. What is blastoma? What is blastoma? What is blastoma? What is teratoma? What is blastoma? Both are embryonal tumors. Teratoma and blastoma are embryonal tumors. Okay. Sometime ago I told you about this, but then I will repeat this again. During development of the fetus, initially, the fetus develops from a mass of totipotent cells. Totipotent cells means these cells has potential to differentiate into any layer, into ectoderm, mesoderm, or endoderm. So it has that great capacity. That means it is a mother cell. So from this mother cell or totipotent cell, then the individual cells arise. That is epidermal cells, mesodermal cells, or mesenchymal cells, and the endodermal cells. The epidermal cells, they differentiate again into the skin, the mucous membranes of various structures and their related glands. The mesenchymal cells, they differentiate into muscle, the bone, cartilage, subcutaneous tissues, fat, areolar tissue, etc. Then endodermal tissue differentiates into the alimentary tract and its related accessory glands. So here we have seen first stage is mother cell, that is totipotent cell. From the totipotent cell, we get the blast cells, that means epidermal cells, mesodermal cells, and endodermal cells. From these cells, we get the final product, the differentiated product. So the first two things, the mother cell and the blast cells, they are called as the embryonal cells. These embryonal cells, they completely differentiate into their related structures. Sometimes what happens is these embryonal cells, some of them, they do not differentiate. So they remain in the fetus, and along with the fetus they grow, they multiply. Once the fetus is born, then these cells can grow and they can form benign tumors or usually malignant tumors. Teratoma is a tumor arising from the totipotent cells. Because it is from totipotent cell, it can produce, the tumor can produce the skin glands, muscle, cartilage, bone, tubular structures like alimentary tract. So all these things you can find in the mass. That is teratoma. So teratoma is an embryonal tumor arising from the totipotent cells, which can differentiate into any type of cell in the body. Then the blast cells. The blast cells, they can produce blastomas. So usually the blast cells are from the mesodermal cells. So Wilms tumor is called as the nephroblastoma. That is, it is a embryonic nephrogenic tissue developed from the mesonephric mesoderm. So it is a mesenchymal cell. So because it is mesenchymal cell, once the tumor arises from this particular cell, there can be muscle, cartilage, bone, etc. in the tumor. So histologically, mesenchymal elements like skeletal muscle, fibrofatty tissue, bone, and cartilage are seen in the tumor. So this is a blastoma. This is called nephroblastoma. It usually arises from one pole of the kidney. Sometimes it may be bilateral. Staging of the tumor. Stage 1, tumor confined to the kidney. Stage 2, tumor extends beyond the kidney with either penetration of the capsule or involvement of the renal sinus, but can be completely removed. Stage 3, with regional node involvement. Tumor penetrating to the peritoneal surface or involvement of the surrounding viscera. Stage 4, hematogenous metastasis to lung, liver, bone, and brain. Stage 5, bilateral renal involvement at the time of diagnosis. It occurs around 2 to 5 years. It is rapidly growing, large lump in loin. So that is the main manifestation of the child. So the mother gets the child to you with the complaint of a mass growing very rapidly in the loin. Hematuria occurs late when the tumor infiltrates the renal pelvis. There may be pyrexia due to metastasis in the lungs and rarely to liver and bones. Lymphogenic metastasis is uncommon. So this is because the mesenchymal tumor, it always tends to metastasize by blood to the liver, so to the lungs, and rarely to the liver and bones. Differential diagnosis: neuroblastoma from adrenal gland. Neuroblastoma is another blastoma, is an embryonal tumor arising from the neurogenic tissue. So this can be from the sympathetic ganglia, or it can be from the adrenal gland. So if it is from the adrenal gland, because the adrenal gland is anatomically related to the kidney, just situated above the kidney, that is why a mass arising from the adrenal gland can mimic the kidney mass. So clinically, we will not be able to differentiate it. Clinically same as Wilms tumor, but metastasis to bone occurs frequently in neuroblastoma. In case of nephroblastoma, metastasis to bone is rare. Then other differential diagnosis to be made in a child is hydronephrosis. A tense hydronephrosis may be mistaken for Wilms tumor. Investigations: urine analysis for hematuria. So presence of hematuria indicates infiltration of the tumor into the renal pelvis. Plain X-ray abdomen, soft tissue shadows and calcifications may be seen. Intravenous pyelography, displacement and distortion of calyces are seen. Ultrasound scan, CT scan. It is useful to study to demonstrate local extent of the growth and infiltration to the surrounding viscera and renal vein. So this, because this is a mesenchymal tumor, it has a tendency to spread by renal vein. So there may be renal vein thrombosis. So CT scan is very, very useful in these cases. So you can see the mass arising from the kidney, its extent, that means whether it is within the capsule or invade the capsule or invade the surrounding structures, that can be evaluated. Then it is also useful to see for the lymph nodal metastasis. X-ray of the chest to demonstrate the secondaries in the lungs. What is the characteristic feature of X-ray of the chest with secondaries? When there are secondaries in the lungs, how they appear on X-ray of the chest? It is not a cotton ball, it is cannon ball. Do you know the meaning of cannon? Cannon means Ferengi. So the balls used to fire from cannon, they will be round spherical balls. So these lung secondaries, they appear like homogeneous spherical masses in the lung region. That is why they are described as the cannon balls. So you can see the large mass arising from the kidney on CT scan. Management: it is the radical nephrectomy followed by adjuvant radiotherapy. Usually these blastomas, they are sensitive for radiation. So you do radical nephrectomy, then followed by adjuvant radiotherapy. carcinoma of the kidney or gravitoma or hypernephroma. So all these things belong to the same lesion. Pathology, it is an adenocarcinoma of the renal tubules. So we have the glomerulus and renal tubules. So this arises from the renal tubular epithelium. So this is an adenocarcinoma. It arises from one pole, usually from the upper pole. It is a highly vascular tumor. It has predilection to spread by blood. Usually, carcinomas has predilection to spread by lymphatics. Blood spread occurs late, but some carcinomas, they exclusively spread by bloodstream. So this renal carcinoma is one example. Can you tell me any other carcinoma which spreads by bloodstream? Hepatocellular carcinoma spreads both by blood as well as by lymph. But some carcinomas, they spread exclusively by bloodstream. Okay. No, Crookenberg's tumor doesn't spread. Crookenberg's tumor itself is a secondary in the ovary. Follicular adenocarcinoma of the thyroid. Follicular adenocarcinoma of the thyroid gland, choriocarcinoma, and renal cell carcinoma, they spread by bloodstream. That is why they produce early metastasis in the lungs, liver, or bone. Actually, it may produce tumor thrombi in the renal vein and may embolize to form secondaries in the lung or bone. You know, thrombus developed because of the blood clot. Apart from the hemothrombus, there can be tumor thrombus. That means all the tumor cells, they invade the renal vein. So once they invade the renal vein, the platelets will agglutinate over that. That becomes a thrombus. So when you study this thrombus, there will be multiple tumor cells will be there. The tumor thrombus, it just appears like the ordinary clot. But when you study it under a microscope, you will notice multiple number of tumor cells in this clot. Lymphatic spread occurs only when the tumor invades the renal capsule. Carcinoma spreading by blood. Other carcinomas which exclusively spread by bloodstream are thyroid follicular carcinoma and choriocarcinoma. So please remember this, because sometimes it is asked in the PG entrance examination. Similarly, sarcomas have great predilection for spreading by bloodstream, but few sarcomas, they spread by lymphatics. They are Ewing sarcoma, synovial sarcoma, rhabdomyosarcoma, and angiosarcoma. These sarcomas, they have predilection to spread by lymph stream. But majority of the sarcomas, they have predilection for hematogenous spreads. Microscopically, the tumor contains polyhedral or cubical cells with small hyperchromatic round nucleus and clear cytoplasm with rich blood vessels in the stroma, because it is a highly vascular tumor. Clinical features: age of occurrence between 40 and 60 years. Males are commonly affected. Risk factors: obesity, hypertension, cigarette smoking. These are the risk factors for developing carcinoma of the kidney. Orientation, painless lump in a loin, either right or left loin. Hematuria. General constitutional differences like anemia, oliguria, and cachexia. Anemia is more frequently seen because the erythropoietin is affected by the tumor, so the patients develop anemia. There may be oliguria and cachexia. There may be pyrexia of unknown origin. Sometimes the patient will come to you with fever, not with the lump. So the patient will be investigated for PUO. So usually you will think whenever pyrexia is there, you will think of a viral fever or some microbial fever or some rare parasitic fever. But POS can occur due to neoplasms also. So this is one example. The other tumors which can produce fever of unknown etiology. So this is called as fever of unknown etiology, or in earlier days it was called as pyrexia of unknown origin. Pyrexia of unknown origin. So that was earlier name, but the recent name is fever of unknown etiology. So they are Hodgkin's disease, non-Hodgkin's lymphoma, hepatoma, leukemia, atrial myxoma, and post-transplant lymphoproliferative disease. So these are the other causes of fever of unknown etiology. Then some patients may manifest due to secondaries in the bones and lungs, particularly ends of the long bones. Bone secondaries are very vascular and may be pulsatile. Because this tumor spreads mostly by bloodstream, the tumor metastasizes to the bones, and the bone secondaries are vascular and may be pulsatile. It has so much arterial supply that actually it may pulsate. Follicular carcinoma of thyroid may also present with vascular bony secondaries. Some rarer types of orientations. This tumor may secrete ectopic hormones. So there may be polycythemia. There may be hypertension. So renin and erythropoietin are the substances secreted by the kidney. So in tumors, sometimes they become hyperfunctional. So the patients may have polycythemia, or patients may have hypertension. Sometimes what happens with a left renal tumor, a left renal carcinoma, I said already, it can produce tumor thrombus in the renal vein. So the renal vein may be blocked by the tumor thrombus. The left renal vein gets one important structure, that is the testicular veins. Left testis drains by Pampiform plexus, which becomes the testicular vein. The testicular veins ascend up and join the left renal vein. On the right side, the testicular vein joins the inferior vena cava, but on the left side, testicular vein joins the left renal vein. So when a tumor thrombus is there, so it occludes the orifice of the testicular vein. So there will be impaired drainage that leads to engorgement of the testicular veins. So whenever the testicular veins are engorged, what is the result? What do you get? So whenever renal vein is very good, renal vein is engorged, so testicular vein is engorged, it produces a condition called varicocele. That means dilatation, tortuosity, and elongation of the Pampiform plexus of veins. That is called varicocele. Varicocele, especially on the left side, due to tumor invading testicular vein. Nephrotic syndrome in old age. Staging by TNM. T1, the tumor is smaller than 7 centimeters. Stage 2, tumor larger than 7 centimeters. T3, the tumor has grown either into the renal vein or into perinephric tissues, and tumor has not spread beyond gyratosis fascia or into the adrenals. The gyratosis fascia means the facial capsule of the kidney is called gyratosis fascia. So it is within the gyratosis fascia, but invaded into the perinephric fat, or it is associated with tumor thrombus in the renal vein. This is T3 stage. Then T4 stage, the tumor has spread beyond gyratosis fascia and extends into the adrenal gland on the same side of the tumor. Then N staging, NX, the regional lymph nodes cannot be evaluated. N0, the cancer has not spread to the regional lymph nodes. N1, the cancer has spread to the regional lymph nodes. The lymph nodes, the para-aortic lymph nodes at the hilum of the kidney, those are the lymph nodes usually that are involved. M staging, M0, no distant metastasis. M1, visceral metastasis. So it can be due to into the liver, lungs, bones. Urine analysis. So the investigations for a case of suspected renal cell carcinoma. So patient mainly manifests with a mass in the loin, a solid mass in the loin. So clinically you examine and you will make it a diagnosis of a solid mass from the kidney. So any solid mass in the kidney should be considered as carcinoma till proved otherwise by investigations. So clinical diagnosis will be carcinoma of the kidney. So then you must do the investigations. So what investigations you do? Urine analysis for hematuria, plain X-ray for any evidence of calcification or presence of calculi, intravenous pyelography. Actually, intravenous pyelography is one of the commonly done investigation for majority of the urinary tract diseases. I repeat again, it is one of the commonly done procedure. It is a investigation which tells you about the anatomy and physiology of renal tract. So how the urine is being excreted, whether normally or delayed or impaired, and the structure, the anatomy can be evaluated. So whenever a mass is occurring in the kidney, the mass gradually is increasing. So the calyx adjacent to the mass will be stretched and elongated. So what you see here, the elongated calyx and with dilatation of the ends of the calyx. So this elongated, narrowed calyx with club-shaped ends. What do you call this deformity? What do you call this? Very good. This is called spider leg deformity. So already we have studied about spider leg deformity. Can you tell me in which other condition there will be spider leg deformity? In which other condition spider leg deformity is there? No, it is not hydronephrosis. It is not hydronephrosis. It is not stones. It is not mass in the minor calyx. It is no. Okay, I will give a clue. Spider leg deformity. Wonderful, wonderful. You are right. It is polycystic kidney. Polycystic kidney, because of the cysts, they cause elongation. So there will be spider-like deformity of both sides and of multiple calyces, not only one calyx. You will see multiple calyces will be deformed with spider-like deformity. Very good. So the features on IVPR: enlarged nephrogram, spider-leg deformity, that is nothing but long attenuated of only one or two calyces. Differential diagnosis of spider-leg deformity: solitary cyst and hydroid cyst of the kidney. Then bilateral spider-leg deformity occurs in polycystic disease of the kidney. So a solitary cyst and hydroid cyst also can produce spider-leg deformity. Ultrasound scan, you will find hyperechoic renal mass and capsular invasion can be evaluated. CT scan, it is useful for detecting perirenal infiltration, hilar lymphadenopathy, and renal vein involvement with thrombus. You can see here the tumor thrombus in the renal vein, and there is a mass in the kidney. Renal angiogram, its use is limited after the usage of CT scan. Before the CT scan, renal arteriography used to be done to delineate the mass. But now CT itself will be sufficient to evaluate about the mass and its vascularity. X-ray of the chest, you can see here, this is X-ray of the chest. You see one spherical or round homogeneous density in the lung. And there is one more thing here. There is one more here. And on the left side also, you find a rounded mass here. Here there is another. So whenever you see such multiple rounded masses in the lung shadows, it is called the cannonball appearance. So this is secondaries in the lungs. So whenever you find a renal mass, what is the differential diagnosis? Abscess in the kidney, angiomyolipoma, metastasis from a distant primary lesion. Sometimes there can be metastasis in the kidney also. Renal cyst, sarcoma, rare tumor arising in the kidney. Management of renal cell carcinoma, partial nephrectomy. Because it arises from one pole of the kidney, partial nephrectomy can be done in some cases. What are the indications? T1, N0, M0 tumor. What is T1? What is T1 tumor? Very good. Tumor which is less than 7 centimeters. Very good. Without any infiltration into the perinephric fat or into the sinus, or without any evidence of renal vein thrombus. So there is only a mass in the kidney without any associated features, and the mass is less than 7 centimeters. So if it is confined to one pole, you can remove the one pole. Then in tumors affecting a kidney with absent or non-functioning contralateral kidney, if the other kidney is absent or non-functioning, only sole kidney is functioning, that kidney develops a mass. In that case, what you do is you go for partial nephrectomy, irrespective of the staging. Procedure: tumor containing part of the kidney is removed along with normal surrounding parenchyma. The second procedure is radical nephrectomy by transabdominal or transperitoneal approach. We have seen transperitoneal approach for nephrectomy or renal procedures in some other condition also. What is that condition? Where you go by transperitoneal route Yes, it is trauma to the kidney. You open the, yes, good, very good. Trauma and tumors are the two conditions where you approach the kidney by transperitoneal route. Because this is a very vascular tumor and has a tendency to spread by bloodstream, the kidney should not be handled before ligating the renal veins. Usually what you do, you go to the tumor, you hold the mass, you separate the mass, dissect it all around, go to the vascular pedicle, ligate the vascular pedicle and remove the tumor with the organ. But here, you should not do like that. First of all, you must go to the renal vein, ligate it, then dissect the tumor from surrounding structures along with the kidney and remove the kidney. So vascular isolation must be performed early. Why? Because this tumor the vein may contain tumor thrombi. So if you handle the tumor first without ligating the renal vein, what will happen? The tumor cells will be squeezed into the renal vein and they will go into the general systemic circulation, and later the patient will develop metastasis. If metastasis develop after removal of the tumor, after surgery, what do you call those metastases? If a patient develops metastasis few months after surgery for the primary tumor, what do you call it? Good. It is called the metachronous metastasis. If primary and secondary both appear at the same time, we call it synchronous metastasis. Sometimes primary is silent, is not visible, not evident, but secondaries are present. Then what do you call that type of metastasis? Yes, good. It is no, it is not synchronous, it is precocious. Synchronous means both appearing same time. If metastasis appear before the primary, then it is called the precocious metastasis. Very good. So the kidney should not be handled before ligating the renal veins because the tumor thrombus may get dislodged, causing distant metastasis. The renal pedicle is isolated first and the renal vein is ligated and nephrectomy is performed. If there is tumor thrombus in the renal vein or inferior vena cava, they are emptied of the thrombus. So what you do is you first open the renal vein and then you open the renal vein, empty the clot, then ligate it. Structures removed. So these are the kidneys and these are the hilar lymph nodes, the renal hilum. These are the para-aortic lymph nodes. So lymph nodes are situated in front of the aorta. Around the celiac artery, supramesenteric artery and inferior mesenteric artery, they are called the pre-aortic nodes. There are lymph nodes situated by the sides of the and the lateral sides of the aorta. They are called the para-aortic. So the para-aortic lymph nodes and renal hilum, they are the draining lymph nodes of the kidneys. So structures removed are entire kidney along with the tumor and perinephric tissue and adrenal gland. So the Gerodes fascia. So kidney with perinephric fat and Gerodes fascia, including adrenal. The proximal 2/3 of the ureter. Lymph nodes from the crest of the diaphragm to aortic bifurcation, including the renal hilar nodes. radiotherapy and chemotherapy are found to be of less use. So this is the structures that are removed in the radical nephrectomy. So kidney along with perinephric fat and gyroids fascia, adrenal gland, upper 2/3 of the ureter, hilar lymph nodes, and para-aortic lymph nodes starting from the diaphragm down up to the aortic bifurcation. So all these lymph nodes are removed. Other methods, of course, partial nephrectomy we have already discussed. Laparoscopic radical or partial nephrectomy. So the procedure can be done by laparoscopic approach also. Cryo or microwave ablation. This is done for very small lesions, and the results prove to be equal to radical procedure. So the lesions are less than 2 centimeters in diameter, then they can be ablated by cryo or microwave. Targeted medical therapy. What is targeted therapy? Targeted therapy is a cancer treatment that uses drugs to target specific genes and proteins that are involved in the growth and survival of the cancer cells. So certain genes are responsible for the growth of the tumor cells, for initiation and for spread of the tumor cells. So if you can identify such genes or proteins, so if you can target some blockers for the growth of those genes, the tumors will regress. So here, thyronase kinase inhibitors are useful to target the vascular endothelial growth factor. So this is one of the things which is responsible for the growth of the kidney tumors. So there will be more development of the vessels here. So if you target these vascular endothelial growth factor, the vessels will shrink in size. The tumor necroses. Tumor do not spread. Similarly, anti-VEGF, that means vascular endothelial growth factor, monoclonal antibodies like bevacizumab, and there are many other antibodies like this. Then mTOR inhibitors. So this is called the targeted medical therapy. So if you can find specific genes which are responsible for growth of the tumor, you can block those genes with certain medications. Palliative treatment, the tumor becomes inoperable. Radiation therapy may be considered as the primary therapy for palliation in patients whose clinical condition precludes surgery because of extensive disease or poor overall condition. Or you can do even renal artery embolization with ethanol or gelatin sponge platelets. If you do renal artery embolization, automatically the kidneys undergo aseptic necrosis. That is equivalent to doing a nephrectomy. Prognosis, it depends upon staging. The 5-year survival rate for stage 1 disease is more than 90%. For stage 2 tumors and stage 3 tumors, it is 50 to 75%. For stage 4 disease and extrarenal infiltration, hilar nodal involvement and secondaries in the lungs or bones, they carry a very bad prognosis. For local tumors, it is 60%, extrarenal infiltration, hilar lymph carry bad prognosis. So that is about the gravid tumor. Any doubts about renal cell carcinoma? This is an important topic because you get the questions in the theory examination about renal cell carcinoma. Similarly, if a mass is there in the loin, definitely it will be given for the students in the clinicals as a long case. So a solid mass from the kidney means it is usually due to renal cell carcinoma. So you will be asked to tell about renal cell carcinoma, so you should know much about renal cell carcinoma. So if you have no doubts, we will proceed to the next topic, that is renal pelvis tumors. That means upper tract transitional cell carcinoma. Already I told you upper tract means it is kidneys and ureters. Tangential cell mucosa is present only for the pelvis of the kidney and ureter. Okay. The pathology of tangential cell carcinoma. It arises from the tangential mucosa of the renal pelvis. It accounts for 5 to 10% of urothelial cancers. It may be multifocal with similar tumors in the ureter and the bladder. So the pelvic tumors may be associated with ureter tumors and the bladder tumors. So this is there in about 40% of the cases. Clinical manifestations: hematuria. It is painless, profuse, paroxysmal. There may be ureteric colic due to blood clot. So usually what the surgeon will suspect is whenever a patient comes to you with ureteric colic, most of the times they consider it to be a urinary calicus. But in elderly persons, you must keep this also in mind. If the tumor blocks the ureter, then the patient manifests with hydronephrosis. Investigations: urine examination for malignant cells, IVP or retrograde pyelography. What is retrograde pyelography? What do you understand by retrograde pyelography? Yes, retrograde pyelography. Intravenous pyelography means you give contrast dye into the veins. The dye is excreted by the kidneys into the pelvis and ureters. Then you take the X-rays. That is intravenous pyelography. Then retrograde pyelography means you don't inject any dye into the veins. Simply what you do is you do cystoscopy. In the cystoscopy, you will visualize the ureteric orifices. Through the ureteric orifice, you pass a catheter into the ureter. Then inject the radiopaque dye into the catheter that is there in the ureter. So you will now demonstrate the ureters there. Because you are directly injecting into the pelvis and ureter, the shadow cast by the retrograde pyelography is clear. Intravenous pyelography means the dye should go into the blood and is excreted by the kidneys, then it should come into the pelvis, then only we'll see. You will see a dilute shadow. But in case of retrograde pyelography, you will see a clear demarcation of the pelvis and ureters. So that gives better information than intravenous pyelography. Then you can ask me why intravenous pyelography? For every case you can do retrograde pyelography. That's true. But intravenous pyelography will tell you about the functional status of the kidneys also. It tells you about the functioning of both the kidneys. So that is why IVP scores superior to the retrograde pyelography. So when you do intravenous pyelography, you can make out space occupying lesion in the pelvis. Tumors in other parts of the urinary tract can also be detected. we have already seen that there may be multifocal disease with lesions in the ureter and as well as in the bladder. So you can see here a space-occupying lesion in the pelvis. So it can be a papilloma, it can be a transitional carcinoma, or it can be a calculus. Can this be a calculus? Can this be a calculus? It is seen as black. Dye is seen as white. The shadow is seen as black. Calculus will be seen as black or white shadow. Calculus usually is seen as white shadow. So white and white, you can't make a differentiation. But I am saying that it can be due to calculus. Calculus means, yes, very good. Some are radiolucent. The radiolucent calculi will give a black shadow like this. Can you tell me what are the radiolucent calculi? We have seen different calculi. We have studied about those different calculi. Tell me what are the radiolucent urinary calculi? That means radiolucent stones are made of what? What chemical substance? Very good. It is urea and uric acid calculi. They are radiolucent. And here you can see a filling defect in the upper end of the ureter. Here you can see the lesion in the lower end of the ureter with proximal dilatation. So whenever there is obstruction, there will be proximal dilatation. Management: nephroureterectomy with a cuff of bladder wall around the ureteric orifice. So the lesion is there in the pelvis of the kidney. You remove the whole kidney plus ureter plus cuff of bladder. Why? Because it is a multifocal disease. Even after removal of this, even after doing nephroureterectomy, later patients may come to you with bladder metastasis. That is why whenever you do surgery for the upper tract transitional carcinoma, you must always advise the patient to come for cystoscopy examination of the bladder once in every 6 months. That's very, very important. By that, you can identify tumors in the bladder at an early stage. So 40% of the lesions can be associated with bladder tumors, either synchronously or metachronously. So this completes the neoplasms of the kidney. Now we'll go to the topic of the infections of the kidneys. Any doubts in the neoplasms? Okay, I'll proceed to infections of the kidneys. Classification: acute pyelonephritis, chronic pyelonephritis. Chronic pyelonephritis can be a non-specific lesion or specific due to tuberculosis. Then other infective condition of the kidneys being pyonephrosis, carbuncle, perinephric abscess. So these are all the inflammatory conditions of the kidneys. The source of infection: ascending infections. It is the most common route of infection. That means the infection acquired through the urethra and prostate, they will ascend into the bladder, from there into the ureters, and from there into the kidneys. This occurs mainly because of reflux, calculus, and stasis. The other route of infection being hematogenous spread from the infected tonsils, caries tooth, infected skin lesions. Similar from lungs, bone, or lymph nodes in tuberculosis infections. Acute pyelonephritis is more common in females, more common during certain periods of life like childhood, puberty, pregnancy, menopause, and immediately after marriage. In children, it is mainly due to reflux. Reflux means, what is reflux? What do you understand by reflux? It is not vesico-urethral, it is vesico-ureteral. Yes, it is ureteral. Okay, good. So normally the urine flow must be from the kidneys into the ureters, from the ureters into the bladder, from the bladder into the urethra. Sometimes there may be reflux of urine from the bladder into the ureters. If the uretrovesical junction becomes incompetent, so when the bladder is filling, some amount of urine regurgitates or refluxes into the ureters. So it is called the reflux disease. So in children, when reflux is there, the bladder organisms are carried to the kidneys and produces pyelonephritis. In adults, due to pregnancy, why in pregnancy the infection is more common? Pyelonephritis is common. Why during pregnancy? Pregnancy is not an immunocompromised state, so don't say that. Yesterday I told you why pregnant women are more prone to get urinary tract infections. No, don't throw stones. I will tell the answer. In pregnancy, due to increased levels of progesterone, there will be dilatation of the ureters, causing hydroureters and hydronephrosis. And because of this, there will be stasis of urine. Stasis of urine always promotes infection. That is why patients will be prone to get infection during pregnancy. Then other condition is called the honeymoon pyelitis. That means in the early marital life, due to more number of sexual intercourses, the bacteria that are there in the terminal urethra may be squeezed into the bladder. From there, they migrate to the upper urinary tract and can cause infection in the kidneys. So that is called the honeymoon cystitis and honeymoon pyelitis. Then calculus and other urinary tract obstructions. These also predispose the adults to have pyelonephritis. Then during menopause, due to atrophic vaginitis and urethritis, they predispose to ascending infections in the urethra and leading to cystitis, and in some cases there will be pyelitis or pyelonephritis. Bacteriology, most of the times is gram-negative rods. Protease, Escherichia coli, Pseudomonas bacteriaceae. It can be due to gram-negative cocci, like gonococci, or it can be due to gram-positive cocci, that is streptococci. Clinical manifestations, there will be general fits of infection like high fever, nausea, headache, and lassitude. Usually pyelonephritis produces severe, very high-grade fever with chills and rigor. It may be associated with nausea and headache. Fever is remitting and associated with rigor and is usually above 39.5 degrees centigrade. Local features: sudden severe pain in the flank associated with rigor. Tenderness in the loin and hypochondriac region. There may be associated features of cystitis, like frequency, urgency, and scalding dysuria. If the case is bilateral and severe, patients can go into acute renal failure. What type of renal failure patients will go in case of severe acute bilateral pyelonephritis? Already we have studied about this point. What type of renal failure patient goes? No, your answer is wrong. Then I will ask another question. What are the causes of, or what are the types of renal tubular necrosis? What are the types of renal tubular necrosis? Very good. Anoxic tubular necrosis and toxic tubular necrosis. Very good. Then what are the causes of toxic tubular necrosis? What are the causes of toxic tubular necrosis? What are the causes of toxic tubular necrosis? So apart from the drugs, the poisons and toxins, what else? Apart from drugs, poisons, toxins, what else? Stroke produces anoxic tubular necrosis, not toxic. Yes, the other cause of toxic tubular necrosis is infection. Bilateral acute pyelonephritis, not glomerulonephritis. Well, pyelonephritis. Do you know the difference between pyelonephritis and glomerulonephritis? Pyelonephritis and glomerulonephritis are the same or different? If they are different, what is the difference? Pyelonephritis and glomerulonephritis are the same or different? Different. In what way? You are right. It is they are different. What is the difference? What is the difference between these two? Okay, I will tell you. No. Pyelonephritis is an infective condition. It is a microbial infection. Glomerulonephritis is not due to infection. It is only an inflammation of the glomerular membrane. Why? It is an antigen-antibody reaction due to hypersensitivity or autoimmunity. There will be thickening of the glomerular membrane, and that produces inflammatory process in both the kidneys. Glomerulonephritis is a generalized bilateral phenomenon. Pyelonephritis usually is unilateral, sometimes can be bilateral. Pyelonephritis is infective condition. Glomerulonephritis is autoimmune disease. Yes, Streptococcus. Streptococcus can initiate the autoimmune process in the kidneys, but Streptococcus is not the direct cause for the glomerulonephritis. It is an indirect cause. Yes. Okay. So in severe bilateral pyelonephritis, patients can go into renal failure. Investigations, urine examination. Yes, glomerulonephritis is not a toxic cause. Glomerulonephritis is not at all related to pyelonephritis. Glomerulonephritis is totally different entity. That is a medical condition. It is an autoimmune process initiated by streptococcal infection. It is not due to direct attack of the kidneys by the streptococcus. So there will be alteration in the antigenicity of the glomerular epithelium and develops antibodies, and the reaction produces glomerulonephritis. Urine examination in pyelonephritis reveals pyuria, that means pus cells in the urine, and urine is subjected for culture and sensitivity tests to know about the type of the bacteria involved and the sensitivity tests. X-ray abdomen for any radiopaque densities. Ultrasound scan and intravenous pyelography for any evidence of obstructive uropathy. So whenever there is stasis, that will promote infection. So once you do urine examination, if there are a lot of pus cells and culture test shows that so-and-so bacteria is responsible, and if the bacteria are more than 1 lakh per ml in a culture population, then definitely you say it is infected kidney. But why infection is there? A normal kidney is resistant for infection because always the urine is flowing down, washing away all the pelvis, collecting ducts, ureters, and etc. But if infection is there, means there is some predisposing cause. It can be presence of a calculus in the pelvis, or it can be an ascending infection. We have seen ascending infection causes. It can be due to reflux, it can be due to stasis, or it can be due to some obstruction in the ureters. So what is the cause? So to evaluate the cause, you must do ultrasound scan and intravenous pyelography. Treatment: rest, high fluid inputs. You must always encourage high fluid input so that high urine output will cause washing away of the urinary tract. Then urinary antibiotics. That means there are certain antibiotics which are secreted exclusively into the urinary tract. The antibiotic treatment should be prompt, prolonged, and appropriate. So how can you choose appropriate antibiotic? By culture and sensitivity test. And that particular antibiotic should be given for a prolonged period of more than 2 to 3 weeks. Usually in many cases of infection in other places, what you do, you give 48 hours after the infection is totally controlled. So that is the period of antibiotic usage. You start the antibiotics, patient gets a response, completely relieved of infection symptoms, then you give it for another 2 days, you give the antibiotic treatment. That is the usual course. But in case of pyelonephritis, you must give it for a period of minimum 2 to 3 weeks. So the antibiotics which are exclusively secreted into the urine being amoxicillin, gentamicin, carbanicillin, ciprofloxacin, and other immunoquinolone drugs. Then alkalization of the urine, if the urine is acidic, example in coliform infections. And of course, you have to evaluate the cause and treat the cause. That means where from the infection is occurring, what is the cause? If there is stasis, reflux, things like that, if they are there, they should be remedied. Next is the chronic pyelonephritis. Reflux is the main cause here. So repeated infections occurring due to reflux produces this neuropathy, chronic. So what is the main histological feature in any chronic inflammation? What is the main histological feature in chronic infections anywhere in the body? The histological hallmark of chronic infection is granulation tissue. Granulation tissue. The histological hallmark of acute infection is edema and vasocongestion or vasodilatation. So chronic infection means there is granulation tissue formation. So what is the sequelae of granulation tissue? So whenever granulation tissue is there, next what will happen? Next what will happen for granulation tissue? Yes, it produces scarring and fibrosis. Very good. So etiological factors for chronic pyelonephritis is reflux, obstruction, calculus. So pathology, there is chronic interstitial inflammation with the scarring of renal parenchyma and dilated atrophic tubules. Seen more commonly in women, age under 40 years in females and over 40 years in males. Clinical presentation, lumbar pain, frequency and dysuria. There will be hypertension. Because of the scarring of the kidneys, there will be pressure over the renin-angiotensin production system that causes the increased levels of renin and causes hypertension. Then it is one of the manifestations is pyrexia of unknown origin. So patient may not have any lumbar pain, but patient may present to you with irregular fever. Then anemia. Most of the chronic renal conditions are associated with anemia because of the erythropoietin effect. Sometimes the disease may manifest as renal failure. So it will be silent and patient comes to you with this renal failure. Investigations, urine examination, pyuria is predominant, albuminuria and CAS are absent. Albuminuria and CAS, what are they? How they produce? How albumin is secreted into the urine? Normally, albumin is not present, but when albumin is present in the urine, what does it indicate? Yes, very good. The filtering mechanism is affected. That is the glomerulus. Whenever the glomerular pores widen, then there will be albumin secretion. So albuminuria is a feature in case of glomerulonephritis. How many types of glomerulonephritis are present? How many types are there for glomerulonephritis? What are the types of glomerulonephritis? You must read nephrology also with these urology topics. I told you in the alimentary tract, when you are studying the alimentary tract in surgery textbook, simultaneously you read the medicine also. Then when you are studying the urology topics here, study the nephrology also. So majority of the nephrology topic in medicine is only glomerulonephritis. As broadly, the glomerulonephritis is classified into acute, subacute, and chronic. The subacute glomerulonephritis also produces a syndrome called the nephrotic syndrome. So in both these conditions, that means in acute, chronic, and subacute glomerulonephritis, there will be albuminuria. But in case of pyelonephritis, which is infection of the pelvis, ureters, the glomerulus is not affected. That is why albumin and albumin casts are not seen. But you may see pus casts. Bacteriology shows causative organisms. Plain X-ray abdomen, ultrasound scan, intravenous pyelography. These three are the basic investigations for any urinary tract disease. So remember these three. Of course, in certain cases where ultrasound scan is not giving much evidence or much information, you go for a CT scan. Treatment, conservative approach. Treatment of causative factors like reflux and stasis or obstruction should be relieved. Antibiotics and high urine outputs. Monitor for signs of renal failure because there is scarring of kidneys. If both kidneys are involved with chronic pyelonephritis, means patients are liable to go into renal failure. So you must monitor. How do you monitor for renal failure? Just I said here, monitor for signs of renal failure. So how do you monitor for renal failure signs? What are the biochemical indicators of renal failure? Yes, very good. You have to see for the blooduria, serum creatinine, and uric acid. Those are the nitrogenous waste materials. Their levels will increase. Then you have to estimate potassium. Potassium also will be rising in case of renal failure. So if you ask me, only if you choose only two monitors, means the two monitors being creatinine and potassium. These two are very important. So monitor for signs of renal failure means you periodically check for potassium, serum potassium and serum creatinine. Surgical management, relief of obstruction, partial or total nephrectomy in unilateral cases, renal transplantation in bilateral cases. Because this is a chronic condition, so it will continue. It is a progressive condition. So the scarring will be continuing, and that will lead to permanent, complete destruction of the renal parenchyma. Prognosis, it is a progressive disease. Pyonephrosis, that means pus in the dilated pelvis. Etiology, it is an infected hydronephrosis, usually following calculus obstruction. It is usually unilateral. Clinical features, there is triad of anemia, fever, and loin swelling. Investigation, urine examination, X-ray abdomen, ultrasound scan, IVP. So what do you find in ultrasound scan? You will find the dilated pelvis. What do you find in urine examination? Plenty of pus cells. X-ray abdomen may show a calculus. Ultrasound scan may show a calculus with dilated pelvis. Intravenous pyelography will show you the hydronephrotic features. So pyonephrosis means nothing but it is a hydronephrosis which is infected, containing pus. Treatment, you have to assess and evaluate functioning kidney. The kidney is normal and functioning, removal of the stone, nephrostomy either by open method or by percutaneous method. With this destroyed kidney, with normally functioning opposite kidney, go for nephrectomy. So the commonest cause of pyonephrosis is calculus obstruction. Calculus obstruction in a immunologically compromised patient, like diabetic patients. So they are prone for getting this pyonephrosis. So what you used to do, remove the cause, that means remove all the stone, and drain the abscess cavity. The abscess is in the pelvis. That's why I put a tube into the pelvis and drain it. Then renal carbuncle. What is carbuncle? What is the carbuncle and what is the cause of carbuncle, or what is the organism responsible for causing carbuncle? Okay, this is Staphylococcus. What is the definition of carbuncle? Tell me. Staphylococcus is correct. Tell me what is the definition of carbuncle. Okay. Some time ago also I asked this question. So okay, I will tell the definition. Please note it and then you by heart it. That's very important. Carbuncle is a spreading infective gangrene of skin, subcutaneous tissues, and kidney. I repeat again. It is spreading infective gangrene of skin, subcutaneous tissues, and kidney. So if you analyze the definition, it is spreading infection. And I said that it is due to staphylococcal infection. Staphylococcal cellulitis, is it localized cellulitis or spreading cellulitis? Usually, staphylococcal infections produce either a localized infection or a spreading infection. Okay, all of you are wrong. Staphylococcal infections, they are usually confined or localized infections. Streptococcal infections, they are spreading infections. The reason is Staphylococcus produces an enzyme called coagulase. This coagulase coagulates the proteins. Because of the coagulation of the proteins, the infection is localized. Because there will be coagulation all around the infection. So that coagulated protein will act as a barrier for spreading of the infection. Streptococcal infection produces a spreading infection. Why? Because it secretes an enzyme called hyaluronidase and streptokinase. The streptokinase, hyaluronidase, they break the tissue barriers. So with that, streptococcal infections widely spreads. But here in renal carbuncle, I said the infection is due to Staphylococcus aureus. And I am saying that it is a spreading infection. So why a Staphylococcal infection is spreading? Because there is lack of resistance of the hosts. The host or host tissues are having less resistance for invasion. Even a localizing infection producing Staphylococcus can produce multiple localized infections. That means there is infection with localized protein coagulation all around. Then by the side of it, again there is one more focus, again one more focus, again one more focus. Then multiple foci of staphylococcal infections will be there. That is because of reduced immunity. So this carbuncle produces spreading infection because this usually occurs in immunocompromised patients like diabetes mellitus patients. So in these patients, what will happen? Staphylococcus produces a localized infection first. There will be protein coagulation all around. In central, there is sloughing. The infection is so severe that it produces necrotic gangrene. So there will be death of tissues with superadded putrefaction. That is gangrene. Why there is so much death of tissue? Because of the high infective nature of the Staphylococcus organism. So there is a localized infection with gangrene in the center, surrounded by protein coagulation. Adjacent to that one more focus occurs. Adjacent to that one, there will be one more focus. That means there will be multiple, some 10 or 15 foci of these localized gangrene areas will be there. So gangrene areas will be centrally, we will see dark black tissue. So like that you will see 10 or 15 black spots. And they will be oozing thick pus. So it looks as if it is like a sieve, gelida. So the affected area will be having multiple sinuses or multiple openings with necrotic tissue and pus. So that is spreading infective gangrene of skin, subcutaneous tissues, and sometimes the kidney due to staphylococcal infection. That is carbuncle. It is infected necrotic mass in the kidney parenchyma due to infection by Staphylococcus aureus. Source of infection, focus of infection anywhere in the body. Normally, Staphylococcus lives as a commensal in the nostrils and in the pharynx, nasopharynx. So there must be some predisposing factors like hematoma of the kidney following blunt trauma, diabetes mellitus, immunocompromised patients, drug abusers. They have also the immunocompromisation. Clinical manifestations, there will be general features of infection like pyrexia, lassitude, anorexia. Local features, there will be ill-defined tender mass in the loin. Urine examination, initially normal, few days later shows pyuria. Ultrasound scan, CT scan show hypoechoic mass in the kidney. So whenever you see a mass lesion, solid lesion in the kidney, we are differentiated from renal carcinoma. Intravenous pyelography, space occupying lesion in the kidney causing displacement or stretching of the calyces. Treatment, antibiotics, aspiration of pus, if pus is fluid and thin. But usually cephalocal pus will be very thick and there will be a lot of necrotic gangrenous tissue in the kidney. So you have to do a open drainage. You have to incise and drain. The cavity is filled by thick necrotic material. The other infective condition of the kidney is the perinephric abscess. It is collection of pus in the perinephric space. Perinephric space is a space between the Gerodos fascia and the kidney capsule. Etiology, local extension from the appendix, liver, cortex of kidney, or renal carbuncle. So any of these things can extend to the perinephric area. So a kidney lesion can burst open into the perinephric space. Similarly, there may be spread of infection from the appendix or from the liver abscess. It may be hematogenous infection of perirenal hematoma. So if there is an injury to the blunt injury to the kidney, we have seen grade 1, There may be a small tear with perinephric hematoma. So this hematoma may get infected. The lymphogenous infection via periuretic lymphatics from the bladder. Clinical features, there are general features of infection, high swinging pyrexia, local features, tender lump in the loin, scoliosis to the side of the lesion, and pain on bending to the opposite side. The mass is there, for example, on the right side, right pyonephrosis. So there is pus around the kidney, and that is situated over the quadratus lumborum muscle and psoas major muscle. They get reflexly irritated. So because of the reflex irritation, the quadratus lumborum and psoas major muscle, they get spastic. They get contracted. So because of the contraction of those two muscles, there will be scoliosis to the side of the lesion. The spine is bent to the side of the lesion. And if you ask the patient to bend to the left side, in right side lesion, patient gets severe pain. You can see here a large perinephric abscess pointing as a large swelling here. Investigations, blood count, leukocytosis. Urine examination doesn't show any pyuria. Plain X-ray abdomen, obliteration of psoas shadow, reactionary scoliosis, elevated and fixed diaphragm, and calculus may be seen if present. Ultrasound scan or CT scan will be diagnostic. Treatment, percutaneous aspiration, if pus is thick, open drainage. Then renal tuberculosis. So Santi has a doubt. If in renal carbuncle, how will Staphylococcus go by hematogenous? Staphylococcus or Streptococcus or any bacteria can spread into the capillaries. So once they enter the capillaries, they can get hematogenous spread. So hematogenous spread can occur to any bacillus. Though they secrete coagulase, they produce localized infection. They can get access to the capillaries in the region. So when they get access to the capillaries in the region, they spread by bloodstream. Renal tuberculosis. Etiology is infection by Mycobacterium tuberculosis. Source of infection, hematogenous infection from lungs, gut, and lymph nodes. The disease is confined to one kidney. The infection starts in the renal pyramid as a granulomatous lesion. So in the pyramid, that is in medulla, the infection starts. Any tuberculous lesion will develop a small cold abscess. So it can produce an abscess in the cortex of the kidney. The abscess bursts, it can produce an ulcer. So once the abscess is burst, that will cause a cavity in the pyramid. So once the pus is evacuated, there will be a cavity. Or the lesion may get calcified. A calcified lesion in the pyramid will produce a pseudocalculus. the infection from the pyramid can extend into the calyx. So there will be chronic calyceal inflammation producing fibrosis. So this fibrosis will produce stricture of the calyx. So whenever there is obstruction plus infection, that leads to pyonephrosis of one pole of the kidney. The infection may spread down to the ureter and produces stricture of the ureter. Then that produces either hydronephrosis or tuberculous pyonephrosis. The infection may spread to the lower urinary tract. That basically can cause tuberculous cystitis and tuberculous prostatitis. The infection may spread to the perinephric space, producing perinephric abscess. So these are the various types of lesions you see in tuberculosis of the kidney. An ulcer in the papilla of the kidney. A tuberculous abscess, if it bursts, it produces tuberculous cavity. If the infection spreads to the ureters, it produces ureteric obstruction and hydronephrosis. If it gets with tuberculous bacilli infection, it becomes pus, called pyonephrosis. Then the tuberculous abscess, instead of bursting into the calyces, it may burst through the capsule of the kidney outside into the perinephric space. So then it produces perinephric abscess. If the host resistance is good, the tuberculous infection heals, or the degenerated caseous material undergoes calcification. So this calcification, if you take an X-ray, they look like caliculi in the kidney. That is why they are called, though they are not caliculi, they are calcifications, but they appear like that. So they are described as pseudocaliculi. Sometimes the tuberculosis infection may involve the whole kidney. So the whole kidney will be infected and get the caseation. So because of the disease of the pyramids, each pyramid is caseated. So the septa between the pyramids will manifest like the septa between the caseated material. So it is septated caseous kidney. Then there may be multiple miliary tuberculosis. That means there may be multiple tubercles over the kidney. So these are the types of lesions produced by tuberculosis of the kidney. Clinical features: age of occurrence 20 to 40 years. It is twice as common in men as in women. Constitutional disturbances are common. The tuberculosis manifestations will be there. There is frequency. Then local features being renal symptoms, frequency, that is the earliest feature. Then renal pain, mild or maybe absent. There may be hematuria, pain during micturition, that is if it is associated with tuberculous cystitis. On examination, abdomen appears normal. There may be associated tuberculous epididymitis, then the epididymis feels craggy. Investigation: bacteriological examination of urine. Already in the general investigations of the urinary tract, we have studied about the tuberculosis infection of the kidneys. Can you tell me what is the picture in bacteriological examination of urine in case of tuberculosis of the kidneys? What do you call that condition? Wonderful. You're right, Manogya, you're right. It is sterile pyuria. Can you tell me other infection where sterile pyuria can be there? What other infection can produce sterile pyuria? chlamydial infection. Chlamydial infection also produces sterile pyuria. So what is sterile pyuria? On microscopy, you will find pus cells. On culture, it is sterile. That means, why sterile? The culture, the ordinary culture, that is nutrient agar culture, can isolate the gram-positive, gram-negative organisms. It cannot show the tuberculous bacilli. For growing tuberculous bacillus, you need special culture medium, like Lowenstein-Janssens medium. That is not regularly used. Only when suspect tuberculosis, then only you go for LW medium, LJ medium. So usually you go for nutrient agar culture. So that will show only pyogenic organisms. So pyogenic organisms are not present, but pus cells are plenty in the urine. That means it is not because of pyogenic organism, but something else. That is tuberculosis. Then when subject the urine for culture in LJ medium, you may see tuberculous bacilli growth only in few cases, not in majority of the cases. AFB staining occasionally demonstrates. Plain X-ray abdomen may show radiopaque densities due to calcified lesions. IVP may show spasm of the calyces because the calyces are infected, inflamed. There may be stenosis of the calyces. There may be hydronephrosis, displacement of calyces due to space-occupying lesion in the renal parenchyma due to a cold abscess or a cavity. Shrunken and irregular bladder wall due to tuberculous infection of the bladder. Chest X-ray may show pulmonary tuberculosis. Cystoscopy may reveal bladder tuberculosis. The tubercles, ulcers, contracted bladder, goal for ureter are seen in tuberculous cystitis. Ultrasound and CT scan will show the distracted kidney or abscess or cavity in the kidney. Treatment, anti-tuberculosis treatment, review by intravenous pyelography for strictures, and if any strictures develop with hydronephrosis, they should be corrected. Aim of surgery to remove the large foci of infection, to correct obstruction. Timing of surgery 6 to 12 weeks after start of the ATT. Procedures, pyeloplasty if there is hydronephrosis. What is the name of this pyeloplasty for hydronephrosis? What is the name of the surgical procedure done for hydronephrosis? No, Boris flap is not for this. Boris flap is for ureteric injury. Whenever there is ureteric injury of the lower end of the ureter, then you go for Boris flap. That is different. Hydronephrosis, you do pyeloplasty. That pyeloplasty is called like the Anderson-Heinz pyeloplasty. Anderson-Heinz pyeloplasty. Very good. Then diversion operations and nephrectomy if there is kidney is damaged. So that is about the infections of the kidney. And there is one more topic, there is a chyluria. There is presence of chyle in the urine. Etiology for chyluria. What is chyle? What is chyle? Very good, Sandy. You are right. Chyle is a type of lymph. The lymph is there in every tissue. The lymphatics drain the lymph from the tissues. Similarly, the lymphatics in draining the intestines, draining the small intestine. They drain the lymph, but the intestines absorb some types of fatty acids into lymph. So when the fat is there in the lymph appears milky. So that is why that type of lymph is called as the chyle, because that fat particles or fat molecules, they are called the chylomicrons. So the lymph containing chylomicrons is called the chyle. So this chyle is present only in the lymphatics draining the intestines. So from the intestines, where do they go? The lymphatics goes in the mesentery of the intestines. They go to the lymph nodes. From there, they go to the thoracic duct. So thoracic duct contains lymph from various parts of the body plus the chyle also. And this chylous lymph will be drained into the bloodstream because thoracic duct empties its contents into the bloodstream. So chyle is present exclusively in the thoracic duct. So why chyluria is there? Chyluria means presence of chyle in the urine. Normally, there is no lymph in the urine. Of course, there is no chyle in the urine. But sometimes chyle can occur into the urine. How it occurs? So whenever there is obstruction to the thoracic duct. What are the causes of obstruction to the thoracic duct? Due to filariasis or due to mediastinal tumors like lymphomas. So in lymphomas, what will happen? The lymph nodes will enlarge to a very huge size. The lymph nodes are there in the posterior mediastinum. The thoracic duct passes in the posterior mediastinum. These enlarged lymph nodes will cause compression of the thoracic duct, and there will be obstruction to the thoracic duct. Or maybe due to tuberculosis, retroperitoneal tumors. So all these things can cause to the obstruction of the thoracic duct. Now you can see here are the kidneys. Here are the various lymph nodes. They are there in the mesentery. So from the mesenteric lymph, that means from the intestines, the lymph drains through the lymphatics in the mesentery. They come to the pre-aortic lymph nodes. From there, the lymph passes into the thoracic duct. The proximal end of the thoracic duct is dilated. It is called the cisterna chyli or cisterna chyli. So from here, the chyle passes in the thoracic duct, goes into the bloodstream and empties into the intrajugular vein. Now, if there is a mass of filial worms are there in the thoracic duct, they cause obstruction. So if an obstruction is there, there will be reflux of this chyle into the various channels. It gets communication. So thoracic duct gets communication from various organs in the body, from the whole, both the lower limbs, from the whole of the intestine, from both the kidneys, from the posterior abdominal wall and anterior abdominal wall. So all this will drain into the thoracic duct. So when thoracic duct is blocked, the chyle will regurgitate or reflux back into the lymphatics draining from the kidneys. So the lymphatics in the kidneys, they are now engorged because there is a reflux flow. So they are engorged with chyle. And these lymphatics that are there in the pelvis of the kidney, they engorge, they become varicose, they become thin-walled, and if pressure increases, they burst into the renal pelvis. Once they burst into the renal pelvis, what will happen? The chyle is leaking into the pelvis and they go into the ureter and collect in the bladder. And when patient voids urine, he will void milky white urine. That is called chyluria. So that is how it occurs. So chyluria occurs because of reflux of chylous lymph from the thoracic duct into the lymphatics of the kidney, where the lymphatics get dilated, they burst into the mucosa of the pelvis or renal pelvis and discharging chyle into the renal pelvis. So clinical feature will be passage of milky urine, sometimes mixed with clots of blood. There will be wasting of the patient, that means the patient will be losing weight due to loss of fats in the urine. Chyle is nothing but fats. Investigations: urine for presence of chyle by doing ether dissolution test. You take a test tube and ask the patient to collect urine in the test tube. The urine will appear milky white. You add few ml of ether. Ether is a fat dissolvent, and shake the test tube vigorously. Then all that milky white urine becomes clear urine. X-ray test for mediastinal widening. Then if it is suspected of filarial infection, you do the filarial antigen test. X-ray test for mediastinal widening means you may suspect the mediastinal lymphomas. So to exclude that one, you have to take this X-ray of the chest. Treatment: if it is filarial cyst, you give diethyl carbamazine, albendazole, and ivermectin. If no relief, cystoscopy is done to locate the side of the ureter which is discharging milky urine. Ureteric catheter is passed, and 1 to 2% of silver nitrate solution is instilled in the pelvis of the ureter. So with that, what will happen? There will be coagulation of the orifices, which were lymph orifices in the pelvis, and they will seal the openings in the ureter. So chyle leak will be stopped temporarily. Again, few months later, there will be leakage of urine. So the prime thing what you must do is you must treat filariasis so that the worms will die and necrose in the thoracic duct and relieve the obstruction. If no relief, renal pedicle is stripped off the lymphatic vessels. So with this, we complete the discussion on the disease of the kidney. So in the next topic, we will go to the disease of the bladder. Any doubts? If you have no more doubts, I missed some topics in the hernia. The last topic, that means the incisional hernia. So just I will complete those topics. Is it okay? Shall I complete those topics? Okay, incisional hernia. Synonyms: ventral hernia and postoperative hernia. Etiology: same factors that favor burst abdomen are also the etiological factors of incisional hernia. Certain factors are more important: obesity, postoperative cough, peritonitis, postoperative abdominal distension, insertion of drainage tube through the abdominal wound. Clinical features: the hernia starts usually as an unrecognized first abdomen with intact skin. So this is a postoperative scar, and you find the hernia here. The hernia may occur through a small portion of the scar or as a diffuse bulge of the whole length of the scar. So the patient came to me with this hernia. I suggested him surgery because there is no complaint except this bulging. The patient denied surgery, and 2 years later he came. You can see such a big mass. Most hernias are broad-based, and hence the chance of obstruction are infrequent. Strangulation may, however, occur due to entrapment of bowel in the loculus of the hernial sac. That means practically any incision can develop hernia. Treatment: conservative. Indications: upper abdominal hernia with very wide mouth, abdominal belt, and reduction of obesity. So patient is advised to wear this belt after reduction of the hernia and reduce the obesity. For upper abdominal hernia, because the mouth is wide, it will not cause obstruction. So if this abdominal support is given, the hernia will not increase in size, usually. Surgical treatment, indication in all other cases. Timing of the operation: 6 to 8 months after initial operation to allow the maturation of scar tissue. Preoperative preparation, reduction of obesity. Advise abdominal exercises to strengthen the abdominal muscles. And if hernia is there for a very long period outside, a large hernia, then to reduce the hernial contents into the abdominal cavity will produce abdominal compartment syndrome. So in such cases, what you do is, first you do prolonged pneumoperitoneum over many weeks to increase the abdominal cavity. Then you do surgery in large hernias. Procedure: there are various techniques for repair of incisional hernia. The main principles are dissection of the hernial sac, reduction of the contents, repair of the defect. Anatomical repair: here the defect can be approximated. So where the defect is approximated without tension, that means less than 2 centimeters in gap is there, then you can go for this anatomical repair. After reduction of the contents, the sac is excised. The defect is closed by suturing the abdominal wall in layers, peritoneum to peritoneum, fascia to fascia, muscles to muscles, with non-absorbable suture material. If required, relaxing incisions are made far laterally. Mesh herniaplasty, it is indicated in all cases where the defect is larger than 4 centimeters. It is the operation of choice. After the excision of the sac, the layers of the wound are dissected. The peritoneum and posterior rectus sheath are sutured. A polypropylene mesh is placed over the sutured posterior wall and secured by interrupted sutures to the overlying muscles. The anterectus sheath is approximated with non-absorbable sutures. If the anti-sheath cannot be approximated, an onlay mesh is switched to the edges with overlapping of the edges by at least 4 centimeters. So a mesh is placed before the peritoneum. That means you suture the peritoneum and posterior rectus sheath. Then place a mesh. Then suture the anterior rectus sheath. If anterior rectus sheath, a big gap is there, you cannot suture it, then place another mesh here and suture it to the anterior rectus sheath. You can see here, a big mesh is placed behind the rectus abdominis muscle. The anterior rectus sheath is sutured. There are a number of other operations which were done previously. They are obsolete now. They are Main-Gott-Skeel operation, Mayer's operation. These are not being done. Now the choice of repair of incisional hernia is by mesh hernioplasty placed pre-peritoneally. That means pre-peritoneal mesh hernioplasty is the operation of choice for incisional hernia. Please remember that. Great process for reinforcement of visceral sac. For bilateral hernia with weak abdominal wall, incisional hernia associated with inguinal hernia, you can place a very large mesh in the pre-peritoneal space. Management of bilateral inguinal hernia. In children, both are done at the same time. In adults, it is controversial. Earlier, it was thought that both sides should not be done. Herniorrhaphy should not be done on both sides. But hernioplasty can be done on both sides at the same time. Then rare hernia, interparietal hernia, interstitial hernia. Here the hernial sac passes between the layers of the abdominal wall. That means that the inguinal hernia is there. Normally, what it will do, it will come out through the internal ring, passes through the inguinal canal, exit out through the external ring, enters the scrotum. There is a normal passage. But sometimes what happens, when it is there in the inguinal canal, the sac protrudes in between the fascia transversalis and transabdominis muscle upwards. Or it can go between the internal oblique and transabdominis muscle. So in between the muscle layers, the hernial sac will have a branch. Then that is called the interparietal hernia or interstitial hernia. So the sac is an extension of the femoral or inguinal hernia. So this is a normal course of the hernial sac. The hernial sac has a branch going upwards between the muscle layers. It is called the interstitial hernia. So then patients will manifest like this. Inguinal hernia will be there, and additionally you will see another hernial sac here. So you can see here an inguinoscrotal swelling, and there is another swelling here. This is because of interstitial hernia. Types, the branching may be in the pre-peritoneal space, intermuscular space, usually between the internal and external oblique muscles, usually associated with inguinal hernia, or it may be inguinosuperficial. Sac expands under the subcutaneous tissues, usually associated with undescended testis and femoral hernia. Clinical features common in males, always accompanies undescended testis. Pre-peritoneal type does not manifest as a swelling, others manifest as a swelling in the inguinal region. Usually presents as acute intestinal obstruction. Treatment, surgery should be done at the earliest. Mesh hernioplasty is advised. Spicelian hernia. It is a type of interstitial hernia occurring through the spicelian fascia at the level of the arcuate line. It occurs at this site frequently because of the diversion of the spicelian aponeurosis into two layers at this site. This is the spicelian fascia. At the lateral part of the rectus abdominis muscle, all the three oblique muscles fuse together to form a common aponeurotic sheet. This common aponeurotic sheet has two layers below the level of umbilicus. So that is why the Spicelian hernia is more common at this place. The hernia expands between external and internal oblique muscles. It occurs in obese females. Strangulation is more common. Treatment is repair of the defect after dealing with the sac. This is the Spicelian hernia. Clinical features: vague abdominal discomfort with reducible swelling at the lateral border rectus below the umbilicus. Usually the swelling is not felt per abdomen. 10% of cases present as strangulate hernia with features of acute intestinal obstruction. Investigations: ultrasound scan or CT scan. Treatment: repair of the defect with the mesh after dealing with the sac either by open or by laparoscopy methods. Of course, this is the lumbar hernia. It occurs through the superior or inferior lumbar triangles. So inferior lumbar triangle, the anatomy. This is the thoracodarsalis fascia. This is the latissimus dorsi muscle. And here are the external oblique muscle origin. And here is the iliac crest. So the space between the iliac crest, posterior border of external oblique muscle, and lateral border of latissimus dorsi muscle is the inferior lumbar triangle. If you take away the latissimus dorsi, then you can see the erector spinae muscle, and you can see the internal oblique muscle here, and here is the 12th rib. So the triangle between the 12th rib, internal oblique, and erector spinae is the superior lumbar triangle. So this can manifest as a inferior lumbar hernia or superior lumbar hernia. Differential diagnosis: it should be differentiated from lipoma and cold abscess. A phantom hernia of periodic individuals. Of course, cold abscess is not required for us here. This is phantom hernia. Phantom hernia means a form without reality. So there is no actual hernia, but it's something looks like hernia. So this occurs in paralytic individuals. So whenever there is paralysis of the abdominal muscles like poliomyelitis, because the flabbiness of the abdominal wall gives an appearance of hernial appearance. That is called the phantom hernia. Next is the obturator hernia. So what is obturator hernia? This is the pelvic bone, and you see here the obturator foramen. As you all know, the obturator foramen is filled with obturator membrane. This is the obturator membrane. And the upper part is not filled with obturator membrane. So that left part is, so the leftover part is called the obturator canal. This is for transmission of obturator vessels and nerves from the pelvis into the thigh. That's why this particular opening is left over here. So the remaining part of the obturator foramen is filled with the obturator membrane. So don't get confused between the obturator canal and obturator foramen. This is obturator foramen. This is obturator canal. So you can see the obturator vessels and nerves going to the thigh from the pelvis here. So these are the obturator vessels and nerves. Now this is covered by the obturator internus muscle, and it's covered by fascia. So you can see the obturator vessels and nerves. This is the pubic bone. This is the pecten pubis, iliopectineal line. And here are the vessels. And this is the femoral opening. So here is the femoral opening. And below the femoral opening is the pubic bone. And below the pubic bone is the obturator opening. So between the femoral and obturator openings, there is pubic bone. This is, of course, levator tendon muscle. If you look from the outside, this is outside the pelvis. This is the hip acetabulum. So this is the obturator foramen, which is covered with the obturator fascia, obturator membrane. You can see the obturator vessels. They have come out to the obturator foramen, obturator canal, and they have a good collateral anastomosis around the hip joint and around the pelvic bone. That is obturator externus muscle, and this is the pectineus muscle. Pectineus muscle is situated in front of the obturator externus. It actually covers the obturator vessels and nerves, and the obturator nerve is going down here like this. Below the pectineus muscle, you can see the obturator nerve. This is the femoral artery and femoral vein. So here is the pectineus, and this is the adductor longus muscle. So adductor longus, pectineus, psoas major, iliacus. All these four muscles forms the floor of the pelvic triangle, femoral triangle. So I hope you still remember femoral triangle. So pectineus is part of the floor of the femoral triangle. So this is to illustrate that pectineus muscle lies between femoral hernia and obturator hernia. So femoral hernia lies in front of the pectineus muscle. Obturator hernia lies behind the pectineus muscle. So obturator hernia is herniation to the obturator canal, common in females more than 60 years. It is covered by pectineus muscle, and hence swelling is not obvious usually. Rarely, swelling manifests deep to the adductor origin. It commonly presents as intestinal obstruction because it is not seen outside as a hernial swelling. So when the hernia gets obstructed, then only the patient comes to you with clinical manifestation of obstructed intestinal obstruction. So even then, you cannot make out intestinal obstruction, the obturator hernia. You have to do laparotomy to relieve the obstruction. Then you will notice that the bowel is going into the obturator canal and obturator foramen. Sometimes patients may have pain related to the knee because this hernial sac may press over the obturator nerve. The obturator nerve gives out the geniculate branch, which goes to the knee. So that is why there will be pain radiating from the groin to the knee. There is a very typical feature of obturator hernia. Swelling may be felt on pervaginal examination. Strangulation is more common because the obturator canal is very narrow. Treatment: as the disease manifests as intestinal obstruction, laparotomy is done, and on exploration, obturator hernia is discovered. Reduction of the contents of the sac is done by incising the neck of the sac parallel to the obturator vessels and nerve. The opening is closed by suturing the broad ligament over the foramen. The bowel is gangrenous, resection and anastomosis is done. This is another type of hernia called parastomal hernia. This is a colostomy. So this woman underwent abdominoperineal dissection, and this is the end colostomy of the descending colon. The normal colostomy looks like this. Sometimes there will be herniation of bowels by the side of the colostomy opening. So this is called the parastomal hernia. It's called the parastomal hernia. This is also ileostomy. This is para-ileal ileostomy hernia. Parastomal hernia means hernia occurring by the side of a stoma on the abdominal wall. Sciatic or gluteal hernia, hernia through the greater or lesser sciatic foramen, presents as sciatica or gluteal swelling. Treatment, mesh repair. Divercation of recti. This is the normal rectus abdominis muscle. Sometimes in some people, this linea alba, this is linea alba in the midline. Sometimes the linea alba gets stretched in some people. So it becomes stretched like this with separation of the rectus abdominis muscles on either side. This is called divercation of recti. It is not harmful. If it develops a defect, it requires surgery. Otherwise, it doesn't require any surgery. So a gap in between the two recti muscles is not hernia. So this is about the hernia. Any doubts? Here is a doubt from Shruti. That is, when oxalates rich food is taken along with milk, the calcium in the milk will be precipitated along with oxalates, forming calcium oxalate in the gut. So oxalates absorption is reduced. So that is what I told. Her doubt is, if this calcium and oxalates are being both absorbed into the blood circulation, excreted by the kidneys, won't they get precipitated in the kidneys, forming calculi? Yes, it is a possibility, but when calcium and oxalates both are taken by mouth at the same time, then they get precipitated in the gut itself. So once they get precipitated in the gut, there is no more absorption of calcium or oxalates. But if they are taken independently, you take chocolates in the morning and take milk at night, then what Shruti has told may become a reality. Otherwise, if both of them are taken, that means if you take a milk chocolate, then there is no problem. Because the calcium oxalates get. Actually, about the library, I'm still working. Anyway, I will put my videos there. Which video you want, Santi? If you have any specific video you want, you tell me. Before I kept it in the library, I can mail it to you. Pancreatitis. Okay. Shruti want yesterday's video and Santi want pancreatitis. That means acute pancreatitis. Complete GIT. Complete GIT means you say I must work on that. Actually, some videos are missing because I failed to record some of the videos. About some 4 or 5 videos I failed to record. Okay, Shruti, I will send you the video to your email ID, yesterday's class. And Santi wanted the pancreatitis, acute pancreatitis. Okay, I will send you that one also to you. Liver also, liver, so many topics are there. Don't tell me so many topics, you just ask me one topic, I can send you the video. Liver is having four classes. Gut is having whole GIT means it will be having about some 15 or 20 videos are there. So to send them means I have to work on them. It's not possible. If you ask me one video, I can send it to you. So anyway, Santi wants pancreatitis and Shruti wants yesterday's class. Okay, sure, done. You will get it by tomorrow evening or at the most today or tomorrow evening. I will send it. Okay, the next class will be there on from Monday. That is about the lower urinary tract and disease of the testis and scrotum. Any doubts? If you have no doubts, I will close this session. Thank you. See you again on Monday at 4 p.m.